Hello. It can sometimes be confusing to know exactly when to refer a child to an orthodontist. So I put together this short video to help um, you know some of the nuances of referring to an orthodontist so you don't miss the window. My name is Neil Woodhouse. I'm a specialist orthodontist based at Dental Specialists. So yeah, traditionally we sort of think we need to wait for the permanent dentition to come in before we can start any orthodontic treatment. And this is often the case for a lot of orthodontic treatments, particularly if it's a crowding case or mild class 2, class 3. The most efficient time to start treatment is once we're in the permanent dentition, so we can have a clean, straight run through. There are, however, a few exceptions to the rules, which I'll cover. Intercepted treatments, time-sensitive, more comprehensive treatments, and also I'll just touch on some of the reasons we might want to actually delay the start of orthodontic treatment. So we'll start with intercepted treatment. Now, this is typically aimed at younger kids, so aged between 6 and 10. And they'll normally be in the mixed dentition. And the important thing to note with intercepted treatment is that it has very limited and specific aims. You can't do everything while they're in the mixed dentition, so you have to bear in mind that it's highly likely they will need more treatment down the line. So the purpose of the intercepted treatment will be to simplify future orthodontic treatments or to prevent any damage to the teeth and gums. So with that in mind, I'll just run through a few examples. Now, there will be more that I haven't covered here. These are some of the main things that I will treat in younger children and why. So the first thing is correction of anterior crossbite. Now, these are really straightforward to fix. Quite often it's just a dentoalveolar thing rather than a skeletal thing. But leaving a kid like this for several years can lead to wear of the incisors, but also we get the pressure from the upper centrals will push the lower centrals labially, and we can get some recession here, dehiscence, which really is hard to sort out later on. So nipping this in the bud, treating it early is my recommendation. Like I said, it can be done with the URA, it can be done with the liners, it can be done with a partial fixed brace. It's usually pretty straightforward to do. Now, posterior crossbite correction is a bit more of a contentious issue. Personally, I don't think there's huge advantages in treating posterior crossbites in young kids. I have been through a phase in my orthodontic career where I did this more, particularly using rapid maxillary expanders. Quite often the kids tolerate it, don't tolerate it as well. In addition to that, they come off a lot. They seem to debond a lot because you don't have as many permanent teeth and you've got shorter crowns for bonding. And it's really hard to retain because they're still growing, and you end up with a very long period of time where you've got to try and retain a posterior crossbite correction. In contrast, the anterior crossbites are self-retaining. If you've got a positive overjet and overbite, they're going to tend to remain in the corrected position long term. So posterior crossbites, I tend to wait, but I appreciate that some people might do that a bit differently. Especially in America, in the US, but in the UK, posterior crossbites aren't generally fixed early. Now the next thing is early class 2 correction. Now we're talking about large overjets here, incompetent lips. Now there are some advantages to doing early treatment, and this has been really extensively researched. There are several really good quality RCTs looking into this. And yes, it works, and you can correct the overjet. And the reasons you might choose to do it at an early age are reducing the probability of dental trauma. It's shown that kids with overjets of 9mm or more under the age of 9 are more likely to suffer a trauma. But fixing that, by the time it's actually corrected, the reduction in probability is fairly modest. It's not as significant as you might think. The next factor is probably the main reason I would do class 2 correction in young kids, and this is if they're getting bullied at school. There's no reason to put it off when it can be corrected if they're having social issues. I think it's of a huge benefit to the child and the parents if you can fix it at an early stage if they're getting bullied. The other thing is soft tissue trauma. Sometimes if you're getting, if you've got a deep bite and you're getting recession in the palate, you're getting stripping of the gingival margins because of a deep traumatic bite, that might be another reason we jump in early. Now the downsides of early class 2 correction, the treatment does become very protracted, and they found that compliance can start to drop off. We all have a limit, and when the treatment starts to go on for 3, 4, 5 years, which it will if you start early, the kids can lose interest, and it can be harder to maintain oral hygiene and compliance with different appliances. The other thing is that the dentition is obviously changing rapidly, deciduous teeth falling out a lot, so yeah, it can be problematic with braces needing to be remade. So habit breaking appliances. Now, kids who suck their thumbs or fingers will develop anterior open bites, increased overjets. It will cause the upper incisors to procline, lower incisors to retrocline. Also, the action of the suction of the cheeks will narrow the palate and cause posterior cross bites. So it's super important that kids stop sucking their thumbs as early as possible. If it's done early enough, we will get spontaneous correction of most of these things. It's quite remarkable, really, but it has to be done around this age. And the important thing in terms of successfully managing to stop a habit is having buy-in from the kid. If you don't have buy-in, they'll usually find a way around things. So the ways it can be done are with a fixed habit breaker, something like this, which will just basically cause a physical create a physical barrier to creating a suction between the thumb and the palate. I actually have had more success with these. This is a company called T-Guard, and they don't supply them in the UK anymore. You have to get them from US, but they work really well. I actually used these on 2 of my kids, and with good success, and get good feedback with this kind of thing. But as I've said before, if you don't have buy-in from the child, it's not going to work. So unerupted teeth are another thing you need to look out for in this age group. It's important that you monitor the eruption of the teeth and for alterations in the sequence of the eruption, or if there's a significant time lag between the left and the right. Normally, if there's a 6-month difference in the eruption of the incisors, you want to be checking with radiographs to see where the teeth are. The earlier we can identify this, the easier it is to manage. And there's a whole manner of reasons. Central incisors particularly can become impacted, whether it's trauma or whether there's a supernumerary in the premaxilla or an odontome, but either way it needs to be investigated and sorted out. So yeah, just something to be vigilant about in this age group. So moving on to more comprehensive orthodontic treatments. Now, typically this will be once we're in the permanent dentition, age 10 to 18. However, there are some exceptions, and it's really important that you're aware of, firstly, what those exceptions are, and also just being aware of the referral system you're entering the patient into. So I'll run through some of the time-sensitive malocclusions that need to be picked up at a certain age, and we'll start off with class 2 patients. So functional appliances, of which these are all examples along the bottom. That's your twin block. This is a fixed functional, so this is a forcer spring, which I use a lot. And this one over here is actually my in-house aligners, which I've built some twin blocks into. Now these work best as a kid is entering the adolescent growth spurt. So that's going to be any time from age 10 for girls, maybe a little bit later for boys, 11, 12. Once you start getting through the adolescent growth spurt and the growth starting to slow down, there are two issues. Firstly, the capacity for the appliances to work well diminishes, but also, and this is just my personal anecdotal experience, I think it's harder from a compliance point of view, particularly if you're using a twin block. It's really hard to get a 15-year-old boy or a girl for that matter, to wear a twin block. It's potentially going to cause some social issues at school, at kind of pre-adolescent time, around the age of 10 or 11 or 12, tend to have better results. That being said, and partly the reason I use the fixed functionals more are they're fixed and they're in 24/7, so they're not compliance dependent. The next time sensitive malocclusion I wanted to touch on is expansion. Now, RME, rapid maxillary expansion, is used to basically separate the suture in the palate and get true skeletal expansion. Now, these are RMEs I've fit quite recently, and yeah, this amount of expansion occurs over the space of 3 or 4 weeks, so it is, as the name suggests, rapid. But once you get to a situation where the palatal suture is becoming more and more fused, your window to do this kind of expansion reduces. There is another technique which can be used in older teenagers, where you put TADs in the palate there, and you basically apply the Hyrax screw, the expansion screw, to the TADs, and then you can do it a little bit later. But in general, once they are in their late teens or into adulthood, then they're looking at needing surgically assisted expansion, which basically involves using one of these devices after they've seen a maxfac surgeon to detach the maxilla, basically. So it's not very pleasant. So better to do it early. And then the other big one is ectopic canines. Again, the potential to correct these reduces as they get older. First of all, if I see someone like this who's got a deciduous canine still in place, if it's early, you can sometimes get or remove the deciduous canine and see some pretty good results with the canines then erupting spontaneously. The problem is if you see them too late, your window for successfully aligning the tooth with a surgical exposure is reducing. So it basically forces me to do a more invasive procedure rather than having that time to try more conservative measures first of all. So really for an ectopic canine, I want to be seeing them ideally around 10 or 11. So yeah, we can look at trying some more conservative measures first. Once they get older, the older they get, the greater the risk of ankylosis. So sometimes, unfortunately, with canines, when you try and move them, they just won't budge, which is upsetting. The other thing is with ectopic canines, it's usually quite a long treatment plan. It can sometimes be 3 years or more. So if you're starting in a 15, 16-year-old, they're going to be having their treatment going into their teens, which into their sort of late teens, even 20s, which can become difficult, particularly if they, are going off to uni or something like that. But also, they get quite fed up, as you can understand. So, yeah, class 2 functional cases, ectopic canines and expansion cases do not want to be left too late. There's no point sitting around waiting for all the permanent teeth to come through, because if that happens when they're 15, your window for doing a lot of this treatment starts to close up. Also just want to touch on some treatments that actually might be advantageous to wait. So first of all, it's if they've got a class 3 skeletal discrepancy. Sometimes it's a very fine line between whether a class 3 malocclusion can be corrected with orthodontics alone, or whether it needs to be treated with a joint orthodontic surgical approach. When it's borderline like that, you have to factor in that the mandible will tend to outgrow the maxilla. So what looks like a manageable class 3 at the age of 14 might look like a more severe surgical class 3 once they get to 18, 19. So sometimes we just sit on those and see how it plays out. Also with hypodontia cases, when there's restorative requirements, obviously you need to factor in that implants might not be feasible until they're sort of 19, 20. I think you get vertical growth in the in men up to sort of mid-20s even. So yeah, depending on what teeth they've got and what the plan is, you might want to just delay things a bit so they're less reliant on dentures or resin bonded bridges. The other thing is, which is totally fine, sometimes the permanent teeth are just slow at coming through. Sometimes they don't come through till 15, 16, and that's okay. If there's no reason to be treating them early, one of the reasons we talked about before, sometimes find parents can start to become impatient and will be putting pressure to start treatment because all their friends have had braces. Some of their friends might have had their braces on and off again. But the truth is, if they're just slow at developing their dentition and you put the braces on early, you could end up with a very protracted treatment, which just increases all the risks associated with orthodontics, with root resorption, decal. So they're sometimes best just to leave alone. And orthognathic surgery, typically it's done in once growing has stopped, so beginning sort of 16, 17 for girls, like 18, 19 for boys. Some people will do class 2 surgery in younger teenagers, but not generally in this area. Just the other thing I wanted to touch on in terms of how you will manage these patients, orthodontic patients in general practice, is where you're referring your patient. Now it's important you know what the waiting times are. If you see a 13-year-old with a severe class 2 malocclusion or an ectopic canine, you just want to bear in mind that they might have an 18-month wait list in the practice you're sending to. So the kid's not going to be 14 or 15 by the time they actually start treatment. And also sometimes you have to be aware that the waiting list, there are often two wait times. One is to be assessed and the other is from the time between assessment and treatment. And different practices manage this differently. Some practices might have a short wait time and will get the patients in soon to assess them and triage them in terms of urgency, and then they'll go onto a wait list to start treatment, whereas others will just have a longer wait between referral and seeing them for the first time. So you've got to understand what you're referring to, speak to them on the phone, and yeah, don't be afraid to take the lead in terms of getting what's best for your patient. There's also, of course, a bit of a difference between the NHS and private provision in terms of how things are managed. See, funding for under 10s in the UK is very different to over 10s. Yeah, different practices might have different protocols on how they'll treat interceptive orthodontic cases and the range of appliances they'll use. So that's one thing to be aware of. And also just in terms of timing and how orthodontic practices manage referrals coming in too early. Some would welcome that and monitor them on your behalf and put them on the reviews, whereas others might just send them back and ask you to re-refer when they're actually ready. So yeah, it's important you have a relationship with the orthodontic practice you're referring to, just so you get a good idea of what they'll accept, because ultimately you don't want to have the responsibility of referring someone in too late and then missing out on treatments. So that's pretty much a whistle-stop tour of referrals. I've covered some of the main points, but of course, you know, it's not completely exhaustive. There might be other reasons you'll refer a patient in, and if in doubt, just speak to your orthodontist, send photos, and yeah, we will give you our recommendations. At Neodent Specialists, we can only provide private orthodontic treatment, but I tend to take the attitude that I would rather see them too early than too late, and I'm really happy to monitor and review the patients as their dentition develops, so we're ready to go at the right time. Yeah, please feel free to get in touch if you've got any questions.